If you get that reactivation TB that ruptures a granuloma, you end up with what's called disseminated TB, miliary TB, or extrapulmonary TB. And this is when the TB bacilli escape. So, like any other person that grew up on Finding Nemo, I had to include our good friend Dory that reads escape. This is when the TB bacilli escape those granulomas and they impact the bloodstream or the lymphatic system. This is where you're going to get the other sites that are going to be damaged by this TB bacilli. You're going to get an increase in the number of tubercles. These are going to be very small in size, typically the size of a pinhead or about 1 to 5 millimeters. And these will start to scatter throughout the body once the TB bacilli is introduced to the bloodstream. These granulomas are going to, or this bacteria is going to gather and multiply in highly oxygenated portions of the body. The most common one that we will see this happen with is the apex of the lungs. So once it gets to the apex of the lungs and it's hitting the bloodstream, we'll see that the regional lymph nodes in that area can be impacted. The kidneys, the long bone, the brain. You'll see that there's even genital TB, spine, major joints, meninges, endobronchial, larynx, and intestinal. All of these are alternative sites to tuberculosis. When we look at the complications, go ahead and put a big circle around hemoptysis. That is a key indicator of TB, hemoptysis. It's not the only one, and TB is not the only disease that's associated with hemoptysis, but it is one that we definitely need to make sure that we are putting those connections together with. Pneumothorax, bronchiectasis, extensive pulmonary destruction, sepsis, malignancy, chronic pulmonary aspergillosis, mental deterioration, intellectual disability, blindness, and deafness. These are all complications that are associated with that disseminated TB and when TB gets really, really bad. So how does one get TB? Well, the transmission is done mostly through aerosol droplets, and this can happen from somebody that has active TB who coughs, sneezes, laughs really hard. That creates an aerosol that is in the air, and all I have to do is walk by, breathe in that aerosol, and I can contract TB. So that's why it's super important for us to have strict isolation procedures when it comes to patients who have active TB. Because that aerosol spray is so fine, those droplets are so thin that they are 0.5 to 1 micrometer. And like I said, those particles can remain in the air after a cough, sneeze, or a good laugh for hours. It's not just a few seconds that those are suspended in the air. This happens for hours. And when those bacteria get inhaled, sometimes that bacteria can get trapped in my mucus and I can sneeze that out. Other times, my body does not capture all of that bacteria, and that bacteria ends up in my alveoli and in my bronchioles. And when that happens, they're in the prime area for themselves to thrive. They're in a prime area for them to multiply. They're in a prime area for them to proliferate and create more issues. Typically, we see this in the apex of the lungs. It does not have to happen solely in the apex of the lungs, but that is the place that we tend to see the granulomas and those tubercles formed when patients have TB. Those are encapsulating that TB bacilli. So make sure that you are doing everything that you possibly can to protect yourself, because this bacteria can be suspended in the air for hours. When we look at additional clinical manifestations, some of the symptoms are going to vary based on the severity of the patient. How sick are they? Which will lead to a difference in symptoms that the patient may present with. But when we look at the clinical manifestations or other signs and symptoms that are associated with TB, they're going to have a persistent cough. This is going to be for 2 to 3 weeks that they have persistent cough. Hemoptysis, again, circle that, highlight that, underline hemoptysis. Low-grade fever and chills, loss of appetite, weight loss, pleuritic, chest pain, and night sweats. So not only do I want you to underline hemoptysis, unexpected weight loss, and night sweats. These are all big key indicators of TB. When we have somebody that we suspect who has TB, what's the first thing that we want to do? Well, one, we want to get them in isolation. But two, the next thing that we want to do is we want to get a sputum culture. So this can be spontaneously obtained, or we can give some therapeutics and some medications so that the patient has an induced cough and they're stimulated to cough those secretions out from the airways, the alveoli and the bronchioles. When we do a sputum culture, we want to get 3 samples, and those samples need to come within 8 to 24 hours of each other. And I have 1 a.m. here as a bullet point. I don't want you to get a sputum culture at 1 a.m. No. What I'm saying there is one of the 3 samples need to be acquired in the morning after they wake up. Remember, the mucociliary escalator is moving all the time, even at night, and it's trying to evacuate and eject any of those particles that could be causing an issue. So first thing in the morning after that patient wakes up, we want to try to get a sputum culture, and we want to get 2 more within the next 8 to 24 hours. When we get that sputum culture, we want at least 5 mLs of sputum. We don't want anything to come from the nose. We don't want anything to come from the saliva in the mouth. We want this to come from the alveoli and the bronchioles and get all of that junk up. So no nasopharyngeal and no saliva. No saliva. So I don't want any, pulling it from the nasal pharynx and then evacuating that, coughing that out. No loogies. We want everything from the chest. Everything from the chest. Other diagnostics that we can do, we can look at a bronchoscopy. We can get a bronchoalveolar lavage. We can look at pleural fluid. We can get a tissue sample. Chest x-rays are going to show us a whole bunch. And then these last 4 here, these last 4 are diagnostics that are specific to TB. So we can get the Mann-Al tuberculin skin test, and that's the PPD that we're used to getting. That's us getting our shot in the forearm and having that read after 48 to 72 hours. We can do what's called an acid-fast bacterial sputum culture. That's where we are evaluating the actual sputum that the patient can produce. QuantiFERON TB Gold, this is a blood test. And then we have the Rapid Expert, the RIF Assay, and we have the Ultra Expert. So a couple of more diagnostics that are specific to TB. When we look at the Mann-Al test, this is the most widely used. This is the PPD, or the purified protein derivative, that is injected intradermally in the forearm, and you can see this wheel or this pinwheel that is produced. We don't want this to be an IM injection. We want it to be just underneath the skin, and then after about 48 to 72 hours, we're going to read or have this read to us. Now, I worked at a facility where the respiratory therapists were the ones that injected this and did the readings. So this is something that we need to know. So the Mannau tuberculin skin test, you inject the PPD, or the purified protein derivative, into the intradermal skin layer. After 48 to 72 hours, we start to interpret these results. The interpretation is, if you have a wheal that is less than 5 millimeters, that's negative. That is conclusive negative. When you have a wheal that still remains and it's 5 to 9 millimeters, this is suspicious, and we have to do some retesting. We have to look at this a little bit closer. If it's greater than 10 millimeters, this is considered positive, whether the patient has active TB right now, whether they have a history of TB, or they were exposed recently. All three of those will generate a PPD, or a wheal, that is greater than 10 millimeters. When we look at the 10 millimeters, it is not a confirmation of active TB. It is a confirmation that this patient has had it in the past, it's latent, or they're in the primary stages of TB, so they've been exposed. But it's not a confirmation of active TB. It just tells us that we've been exposed to the TB bacilli. And there could be a possibility that there is what's called developed cellular immunity to the bacteria, which is a fancy way of saying that the patient has latent TB, or developed cellular immunity. They're in the latent or dormant phase of TB. When we look at the acid-fast smear, this is staining the sputum. This is from a sputum sample, and we have two different tests that we can do here. We can do the Ziehl-Neelsen stain or the fluorescent stain. When we look at the fluorescent stain, you're going to have a dark background with yellow bacteria. When you look at the Ziehl-Neelsen stain, you're going to have a blue background with a red bacteria. So two different diagnostics, or two different tools that we can do, that we can use to evaluate the sputum culture. When we do our sputum culture, we have a couple of other things that we want to do. We don't only want to see those pretty colors with the fluorescent and the Ziehl-Neelsen, but it's necessary for us to differentiate between the Mycobacterium tuberculosis and any other acid-fast organisms. So we could look at non-tuberculosis acid-fast mycobacteria. COPD patients are known for having a non-tuberculosis acid-fast mycobacteria. So we want to differentiate that a little bit more. We can also identify if the strain or the type of TB is drug resistant. And if it is, or if it isn't, I can still identify which antibiotic the bacteria is sensitive to, meaning I can identify which antibiotic I'm going to use to kill that bacteria. So the downside to this is it can take up to 6 weeks for colonies to appear in this culture. So it doesn't always give us a real quick understanding of what's going on and getting the patient on the right antibiotics, but it is something that we still can use because it can be beneficial, because the sooner I know, the sooner I can make recommendations to get the patient on the right therapeutics. When we look at the QuantiFERON TB Gold test, what this is a blood test. So the first one was the PPD, the second one was sputum culture. This third one is a blood test. So with this blood test, we can diagnose the M. tuberculosis infection. This will include latent TB. We use this in addition to the chest x-ray, to the AFB, and the PPD. So this we would use in addition to those other exams. And then we have the Expert MTB, the RIF-Assay, and the Expert Ultra. These come from the sputum sample as well. These are kind of highly sensitive, or more sensitive and specific to detecting the M. tuberculosis and rifampin resistant mutations. So if we have an antibiotic resistant mutation of this bug or this bacteria, we can identify it here using the Expert MTB or the RIF Assay. The great thing about this is there's a quick turnaround time, 2 hours, versus the 6 weeks that it could take with the AFB. When we look at the Expert Ultra, the great thing about that is it is even more sensitive to recognizing, detecting the M. tuberculosis bacteria and any drug-resistant mutations that may have come up from this bug.